Welcome, everyone. I'm so glad that you're here today. My name is Mary Maida. I'm with Canine Cancer Alliance, a nonprofit that's dedicated to advancing research and education, access to better cancer treatments for dogs. We help support clinical trials like the Yale EGFR HER2 vaccine, as well as studies on the gut microbiome and immunotherapy, all with the goal of making future treatments safer, much more effective, and also affordable as well. And none of this is possible without donations from dog-loving individuals and families like yourselves. So if you find today's session valuable, please visit our website and consider supporting research by becoming a monthly donor. Your sustained support makes a huge difference for researchers that we're working with. Today, we're super thrilled to welcome Dr. Guannan Wang. I first met Dr. Wang at the Veterinary Cancer Society conference last fall, and then again at the Pacific Northwest Oncology Group meeting in January. The more I learned about her work, the more excited I was, and I realized how important it is for dog parents and veterinarians to know more about this new genomic test, comprehensive genomic profiling, or CGP, that she's helped develop, and it's now available through veterinary clinics. Just too often, we're told that there are no options for aggressive cancers, but thanks to advances like this one, new options are emerging. And today's talk is all about what that means for dogs and for people who love them. So I'd like to turn this over to Dr. Wang.
Hello, everybody. Good afternoon, good morning. And thank you so much for being here. Thank you for the warm introduction, Dr. Maeda, and this wonderful opportunity to educate and engage our pet families about these emerging tools in our journey against pet cancer. So we're thrilled to be here. So let me share my screen. I have a prepared about like 20 slides so we can quickly go over what our service, what our vision, our approach, and what our service is about and what that means for pet families. So without further ado, all right, my name is Guannan Wang, and I'm a genomic scientist. So I'm the founder of VetOmics. We are a genomic diagnostic company committed to delivering high quality, high actionability genomic diagnostic tests for pets with cancer. Our mission is to transform cancer care and improve outcome for companion animals using cutting-edge omics technologies and precision medicine solutions. So as most of us know that in recent years, precision medicine has really revolutionized how we treat cancer in human patients. It's really shifting away from the one-size-fits-all approaches to targeted therapies tailored to each individual's genomic and molecular differences. In human medicine, as we all know, tumor genomic profiling and genomics-guided treatments are now standard care. So this evolution is really made possible by breakthroughs in genomic technologies such as next-generation sequencing, big data, and the growing arsenal of targeted therapy, immunotherapy, and other novel therapies, most of which are developed and used in the context of genomic and molecular biomarkers. But in veterinary medicine, so we're not quite there yet. Adoptions, speaking from my own experience and a lot others, adoptions has been limited. This is primarily due to, the major knowledge gap of canine cancers, because most canine cancers are studied through human models. And so this does not give us a complete picture of a dog tumor genomic landscape. It's nice to be able to leverage the human knowledge, but we have to acknowledge, the canine specific tumor mutation profiles. Secondly, I think a lot of the clinicians are, experience this pain acutely, is that we don't have enough primary clinical data in dogs. And most of the time we infer the biomarker or drug associations from our human equivalents. But this information is invaluable, but we cannot just assume that it translates perfectly to dogs. And lastly, access to reliable and advanced targeted therapies is still limited for dogs, and the cost can also be prohibitive. So these challenges and limitations have weighed on us for years. That's why when we founded VetOmics, we made it our mission to address them head-on with innovative approaches. So first, we use comprehensive genomic profiling to understand each dog's cancer and every cancer type in an unbiased way. Now that the genomics is under control, I can finally say that in my more than 10 years in this field that I feel comfortable with the genomics. We got it covered. But the lack of primary canine clinical data remain a significant gap. Fortunately, we do not have to start from scratch. We can leverage the rich human knowledge, but in a right framework. That's why we propose a hypothesis-driven clinical study, combining comprehensive genomic profiling with real-world clinical data modeling to validate the translational evidence. In addition, we also collaborate with pharmaceutical partners to support veterinary drug development and repurposing using genomic and clinical insights to bring new treatment options to life. So our Canine CGP is our flagship test. Canine CGP is a whole exome sequencing assay that analyzes all major mutation types across 20,257 coding genes. This is the world's largest assay for dogs. This is like next level. We call it comprehensive genomic profiling, but this is the next level comprehensive, even compared to some of the FDA-approved human tests like Foundation 1 or MSKCC Impact, which only covers a few hundred genes. Other canine tests that are currently available cover far fewer genes. We believe our approach is essential in this stage as we are still accumulating knowledge for canine cancers in order to gain unbiased necessary insights into every tumor and to make the best decision possible. Canine CGP can be used for any cancer types in both research and clinical settings. Canine CGP is in clinical settings. Canine CGP offers the highest chance of identifying key driver mutations and potential actionable biomarkers to guide diagnosis, prognosis, and effective personalized treatment planning. Our test is validated to have exceptional performance with 94% sensitivity and 99.994% specificity at 200x coverage in tumors with as low as 10% tumor content. Canine CGP works with across a wide range of sample types. Some of the common ones you might hear: FFPE, FNA, fresh frozen tissue, blood, urine, bone marrow, a fusion. So we are also turnaround time when we consider a diagnostic test, right? Turnaround time is also critical to consider.
So Guannan?
Yeah.
So I thought that you needed a solid tumor sample, but you're saying that you can get blood sample, urine sample?
Yeah. Absolutely. Yeah. So blood sample for leukemia cases, right? So because we want to sequence the cancer, we want to sequence the tumor sample. If it's a leukemia and it's in blast stage, and we can definitely use the whole blood. We've tried that multiple times and it's a great success. And we can try urine sample for transitional cell carcinoma, like a urothelium carcinoma in urinary bladder. So just yesterday we got 2 urine-based slides, so we can definitely do that. And if we have, for example, if we have a heart-based tumor, for example, hemangiosarcoma, right, and the patient has a fusion, and so the idea is that the tumor will shed into the the very confined compartment, and so we will pick up a lot of the tumor cells in those fusion samples as well. So we have done all these sample types and has been successful.
I see. So I think a lot of people are familiar with the cadet test,
Yes.
BRAF mutation test.
Yeah.
So
Yeah.
can you effectively do the BRAF test then? Is this a
Yes. Yeah.
replacement for cadet
So
test?
now I would see it's so two parts. We can definitely do the urine based, right? So the disadvantage is that without knowing the sensitivity of the cadet, but I think it's a DDP digital PCR. So I think the sensitivity is a little bit higher for the digital PCR test than our NGS test because we cover so many genes. We cannot sequence it to such depth, but they can easily, they only cover like literally one site of one gene, right? So they can sequence it much deeper. So the sensitivity, I think it's not as high as the cadet test. That being said, so the advantage is that if, like our test is validated to detect mutations confident with high confidence in as low as 10% tumor purity, right? That means that if you have 10%, 10 tumors in 100 cells, we can pick it up with high confidence. And that's really good. And, if with a similar above 10% tumor purity, so our test can offer so much more than just the BRAF test. So we can have, not only detect the BRAF, but also, many other genes that could potentially function as drivers.
It's great to know. And how about early detection then? There are several early detection tests, right? Like the NuQ test and the dog sniffing test and worms, Oncotype tests, and they have all pretty high positive, false negative rates.
Yep. Mm-hmm.
And is this test, can it also do early detection?
Yeah. So this is my view on early detection has been pretty conservative. Also because I think we are still at the knowledge accumulation stage. We really need to know what we are dealing with before we detect. We design these like more specific tests, right? Only measure like certain genes, like a big and have high false positive and high false negative. So the idea is that I think we're now doing tumor profiling, right? So for dogs that already have cancer, and if we have a baseline tumor profile, tumor mutation profiles, then these mutations, these can be used, for to develop, future early detection tests. So this is only, like a NGS based, right? So I know there are also like other technologies that are emerging, but I have yet to see a winner in this space that have really high sensitivity, high specificity that, we can reliably offer. And the cost is another huge hurdle as well. So I think we want to take it slow and really accumulate data and hopefully design, a more unbiased, comprehensive test that can, pinpoint a lot of the common mutations across cancer types. I think that's the approach that we would take. Great question. Yeah. So, our turnaround time is another big factor to consider for a diagnostic test, right? So we have our test has been streamlined to 5 to 14 days, which upon sample arrival, which is amazing. So, we're so super happy about, like the current workflow, current schedule, batching schedule, and a lot of the credit goes into, our partner service providers for that. But and this turnaround time is better than most human diagnostic tests, not to mention in the canine space. So I'm very proud of that. Yeah. And if you have like a urgent case, and we somehow we expedite that as well. So yeah, it's not unfathom that to get your genomic results within a week. So with canine CGP is a large genomic footprint, right? Basically, we are covering the entire coding exome. So it enables genomic guided therapy across a wide spectrum of treatments, including targeted therapy. In the conventional sense, these are the small molecule inhibitors, immunotherapy, chemotherapy, and radiation in both single agent and combination settings. Currently, Canine can match and recommend all targeted drugs that are available for dogs' use and certain immunotherapies that Dr. Maeda are working with. As new drugs emerge, so this is the beauty of it. As new drugs emerge, Canine will seamlessly support biomarker and patient stratification for new drugs because we already analyze all genes with potential biomarker associations. Interestingly, I think more doctors come to appreciate that is that Canine can also guide standard of care therapies such as radiation and chemotherapies based on mutation biomarkers. So this is really to unlock the potential for precision use of standard of care therapy as well. So this all sounds pretty amazing on paper, right? So how does Canine perform in real world? So far, we've completed Canine on 244 clinical cases. So this spans over 60 cancer types. Now, I know some doctors prefer to send us certain cancer types because they see the benefit of using genomic testing in those cancer types. But overall, from our end, so we actually see a pretty rounded up cancer representation of all cancer types. We have not one single case failed to generate high quality meaningful data or even needed a second sample. So only 18 cases required a second attempt of our workflow, such as a DNA extraction or library prep or sequencing, and these are all successfully resolved. So why is this important for us? It's because we strive for excellent quality. Right, so I think this is the given that we are introducing this new novel cutting edge tools into the care of our pets, and we want to make sure that quality is default, and that's our job to maintain a high standard of quality. So that part, so it's very, very stringent on our end. And we, in every case, so we identified the putative pathogenic mutations and the clinical actionable biomarkers. That means we have 100% success rate in generating treatment insights. Now we know that treatment remains the top reason, right, for genomic testing. We have others, but treatment remains the top reason. And every single case so far we sequenced received at least one treatment options with an average of 3 options per report.
So Guannan,
Yeah.
Is it possible for your test, for example, my first dog had soft tissue sarcoma, and she had, with soft tissue sarcoma, it's well known that chemotherapy doesn't work very well. So she had a very aggressive surgery, and then she went in for 3 weeks of radiation therapy. And with your test, is there a chance that there may be a chemotherapy option that works for soft tissue sarcoma?
Yeah, depending on the individual case, depending on the individual, really, right? So I would say that we definitely see certain chemos. Honestly, we don't normally prioritize because the evidence associated with chemotherapies, the biomarker evidence associated with chemotherapy is less compared to the target therapy or immunotherapy that are developed in the context of genomic biomarkers, right? And this is understandable because of the nature of chemotherapy is a non-selective, all-cell killer, right?
Yeah.
So, but we do see, actually just shared some some slides with my European doctors that that have this exact same question, right? Can we prioritize the chemotherapies for solid tumor, right? Because that has been considered very difficult based on either in vitro or mutation biomarkers. So we can, but it's not always. We always find better targeted therapies with higher evidence over biomarkers that associates with chemotherapies. So that's why we want to prioritize those.
No, I think last time I saw this slide, you had immunotherapy N of 1, and here I see N equals 4. So can you share what those 4 are?
Absolutely. Yeah. We have the PD-L1 inhibitor, gilvatinib.
Gilvatinib.
Yeah. We have the Torregen vaccine, which is a autologous vaccine. And we have the Alliance vaccine, which is also autologous vaccine, but they have also include the T-cell priming component as well. And we also have the Yale vaccine. So Yale vaccine, EGFR, HER2 vaccine. So we actually have more. We have the EPA vaccine that are, primarily used in Europe, but I know some doctors start to use that in the States as well.
What is it called again?
AVI vaccine.
How do you spell it?
AVA.
Okay, Evivac. Okay.
AVIvac. Yes. It's developed in Europe, but I know some doctors here use it as well. So it's actually 5 that we often recommend.
So there's also Ardent. Ardent Animal Health has autologous vaccine as well. They're similar to Targen. Yeah.
Okay.
So Elias, Torgen, and Ardent are 3 autologous. They use autologous vaccine.
Okay.
So tell me, what kind of mutations would lead you to conclude that autologous vaccine might be more helpful?
Absolutely. So the mechanism of how autologous vaccine is, of course, for new antigen, right? Presenting to the antigen presenting cells. And so for tumor cells to effective, I feel like I'm really talking out of my depth here, but I'll try. But for tumor cells to present these new antigens in order for the immune system to recognize, you have to have a minimal load of new antigens. That's why tumor mutation burden has been a major biomarkers for autologous vaccines in human as well. So that's like a big indicator. Of course, tumor mutation burden has also been a big, most validated, established biomarker for PD-L1, like immune checkpoint inhibitors, like gilvatinib as well, right? But for immune checkpoint inhibitors, we also have many other biomarkers. But for autologous vaccines right now, because we have very limited data, especially in the canine space, tumor mutation burden is our primary indicator to use a autologous vaccine.
Oh, okay.
Yeah.
I have been on, I just haven't been able to see me. Have you done many melanoma samples, Guannan?
Yes, we have. Yeah.
So the human literature shows some EGFR expression in human melanoma. What's your experience in the canine sample you get?
I haven't really systematically analyzed all my melanoma cases specifically for EGFR, but I know for a fact that we found EGFR, HER2 also called ERBB2 and ERBB4, this family amplifications in melanoma cases.
This is an evolving technology, obviously. And so the more genes we find in the future, for example, at least linked in human, that your model is based after labs that have done this in humans, of course, for now many years. And is your database sort of compared, or do you add to your own database relative to what's found in humans? I assume that's a guide for you.
So I would say 3 sources for our, we call it knowledge base, right? One big source is the human precision oncology knowledge bases. We use a few of those. And the second is literature sources from the canine space, canine literatures. And we primarily focus the therapeutic associations. For example, if we have a study that evaluating BRAF with vemurafenib, right? So those are the study that we prioritize. We prioritize canine data, obviously, over human data. And from the human data, we have different levels of evidence level, right? So for example, level A is FDA approved or guideline consensus, right? NCCN guideline consensus. And we have level B, for example, is well-powered, large-scale clinical trial data. And we have level 3 is clinical data, right? Small cohort. And level D, it considers all in vitro study, in vitro evidence, mouse, cell line, and all that. So it's a really well-defined, layered approach. And the third source, I would say, is what you just mentioned. We're now accumulating our own data, right? We have both the mutation, genomic data, that deep exome sequencing data. We don't yet have that in canine space. Right now we are approaching 250 cases, and there's a huge amount of data. And we are also launching our own hypothesis-driven clinical studies where we can, study in real-world patients whether, a patient, received a genomic-guided treatments, respond and benefit from it, right? Compared to historical standard of care data, historical data. So yeah, those are the three main sources. And I would say that eventually we want to have more canine data, right, than human data right now. So we leverage the human data, we infer from the human data because it's a rich source for us. Basically we use humans as our model animals. It's a nice change, right? Because dogs, are always considered model animals for humans. But in this case, humans are actually our model animals.
Since you got Mark here, can we talk a little bit about osteosarcoma and hemangiosarcoma and TCC? I think I remember there was a big study with dogs with osteosarcoma who were given rapamycin in addition to traditional, after surgery, and they couldn't really see
Carboplatin, I believe.
Carboplatin, yeah. And I don't think they could see any benefit from rapamycin. But do you see with any of the data so far, any targeted therapy that does help dogs with osteosarcoma?
Absolutely. Yeah. So in my previous role, so we were going to, collaborate on that study, right? So I think there are a couple of thoughts on that study, right? So the patients are not stratified, right? So if you use rapamycin on any dog with osteosarcoma, you might not hit the ones or have a significant effect on the ones that could respond to rapamycin mTOR inhibitor. Right? So that really dilute the overall benefit. And second of all, I believe the authors did follow-up study that rapamycin, the PK/PD, so it's the concentration in the blood. So it's not enough to mount a response. So I think those are the two things or there could be more, right? But from our perspective, I highly suspect if we stratify patients, because in our case of osteosarcoma, not every one of them, not even a huge percentage, are supposed to respond to rapamycin. So osteosarcoma has very, unique profiles. We can tell just based on the genomic mutation profiles, which one is osteosarcoma, which one is hemangiosarcoma. So they have very unique landscape mutation profiles. But, I don't see that, a huge percentage would respond to sirolimus, to rapamycin. So one is lack of biomarker stratification. Two is the drug PK/PD.
So, Mark, your trial has an enrollment criteria that says if the dog is on another immunotherapy, they can't enroll. It has to be monotherapy, EGFR HER2 vaccine therapy, right? But it doesn't say you can't be on targeted therapy, and you're encouraged to get chemo. So if they do have tumor samples, they could potentially look for targeted therapy to try in conjunction to your vaccine.
The answer is maybe. So, for example, rapamycin kills off the cells that are important for making antibodies. So they would have to be off rapamycin for a period of time, probably a month or more before getting our therapy. And there are exceptions that I can address specifically by the drug, for example. Rapamycin is not commonly used in human osteosarcoma, so I think its efficacy is not only unknown in dogs, but certainly not commonly used, or it's not a go-to drug in human osteosarcoma.
I just want to add one more comment. I think I see from our practicing clinicians, right? So of course, from our standpoint, is to collect clean data. Okay, so if this drug is on monotherapy based on this mutation, let's see how they do. In reality, it's oftentimes combined with cytotoxins or with other targeted therapies, and or with now we have a increasing amount of immunotherapies. I think to tease out which one actually works is it's not impossible. It just requires more data. It requires larger cohort for us to tease out which one actually works. So that's like a mindset change for us as well, and as we go deeper into this space. But it's the reality because the doctors they want to control the tumor, right? So whichever works, we want to provide some framework. Okay, at least don't use a PARP inhibitor or a cycling inhibitor in tumors that don't have those mutations at all, because it won't work and it will add to the toxicities. So those are the framework that we are trying to make aware. And it's definitely a journey, and it requires a lot of education.
So, with standard of care for osteosarcoma, dogs with osteosarcoma, usually surgery followed by carboplatin. Do you think there are targeted therapies that are potent enough and long-lasting enough to replace carboplatin?
And I wouldn't say replace, I would say complement. For example, if we see an osteosarcoma with extensive copy number alterations, right? And this is a hallmark of canine osteosarcoma. The genome is very, very much messed up, has a lot of copy number alterations. Then, and if we see mutations or deletions in genes that are involved in double-strand DNA repair or recombination repair, right? So we would recommend a combination of PARP inhibitor, olaparib, and carboplatin, because the added benefit, will, give the best success rate to, control the disease. So, olaparib and the carboplatin is oftentimes, if we see those kind of mutation profiles, and we would recommend that combo. So it's not really replacing the standard of care therapy; it's complementing, right, to increase the success rate.
I'm concerned that when we're adding more and more treatments, the cost becomes more and more prohibitive. Surgery is already super expensive. Chemo is just outrageously expensive now. And then targeted therapy, it just starts to. I wish and I hope that we will be able to subtract some therapies in the future, especially chemotherapy.
So here's we actually now that we started to follow up on our cohort, right? So we haven't existed for too long, and we are only starting to follow up on our patients. And so it just occurred to me recently that I know a lot of the doctors, they pretty much exhaust standard of care therapy, right, before they seeking for other genomic guided therapies, immunotherapies. In that sense, so if we pretty much know the outcome, right, of the standard of care therapy, which we do for some common cancers, right, hemangial, osteo, melanoma, can we do the genomic profiling and start genomic guided therapy early on if we already know? That's a concept that I'm pondering, right? So can we see the benefit? And this is a not crazy thinking too, because from the human space, when precision medicine was first taking shape back in 2010, around that time, So a lot of the target therapies were approved as third line, fourth line after you pretty much exhaust all standard care therapy. But now a lot of these genomic guided or biomarker guided treatments, they're actually approved early on as first line, right? So I think it's not crazy to think that if we know the outcome of standard care therapy, maybe bringing in these newer treatments would benefit the overall survival, right? So I understand we need a lot of data to make that happen, but I think that's our combined effort, combined goal here as well, right? Eventually, hopefully, we don't have to always add on, so we can start with the best treatment tailored for that specific patients. Yeah.
And in your case, you don't necessarily need surgery. You just need biopsy sample. Is that right?
Yeah, we can do biopsy sample. We can do, like in the case of osteosarcoma, we often use biopsy sample, and the sample has to be non-decalcified. Yeah, but for others like lymphoma, an aspirate will do, right? Like for leukemia, a purple top will do, and for TCC, a urine-based cytospin would do. So it really depend on what cancer we're talking about and which tumor type. But we see, like a half and half FNA sample versus FFPE sample.
So in human medicine, that we're learning that earlier immunotherapy started, the better. But you think that targeted therapy earlier that started, that may also be better before even surgery, before chemotherapy.
No, I mean surgery, right? So I think surgery, we still, if you can do surgery, I think surgery is, I wouldn't argue that, target therapy, although in this setting, target therapy might be used to shrink the tumor before surgery, right? So I know a lot of times chemotherapy is used or radiation is used to shrink the tumor before they take out the tumor, right? So they have less load, less tumor load. But if we know, what the tumor target is, it's not crazy. Although I have to do more research on that one. That's just, Yeah. But I know a lot of doctors that use target therapy as maintenance therapy after surgery. Yeah, that's a fact, and it has been proven pretty effective for a lot of cases.
And is it only oncologists who can order your test, or can the general practice vets now order the test?
Yeah, we have quite some general practitioners order from us as well. Yeah, so I think it's really primarily our client base is oncologists because they are responsible for actually treating the patients with these drugs, right? But to have that information early on, I think will help everybody to make the best decision moving forward, to make the decision, like.
So, Guannan, important to probably some of this audience watching is whether pet insurance or different insurance companies cover the costs of your service. Can you talk about that?
Yeah, I know a lot of insurances cover our cost of a test. So our company, we haven't made any contract or partnership with any of the insurances, but from my experience and our current client base, so I do know that a lot of this is covered by a lot of insurances. The problem is, and we still have a pretty small percentage of pet owners who have insurance, right? I think that's the issue there. But if you do, most likely it will be covered.
I can't stress enough the importance of having insurance this day and age. Every time I see the credit card charge each month for roughly $200 for our 3 Goldens, then I have to remind myself, I do the calculation to say, okay, if one of them gets cancer, then I'm easily going to be, if I didn't have insurance, I'm easily going to be spending $10, $20, $30,000 to help, extend their survival times. And it is possible these days because of new treatments and especially immunotherapy, they can survive much longer, but it really costs a lot now. And we are, and Mark is, and people are working on new therapies that are going to be more affordable. But the reality is today, just like surgery, chemo, everything is costs $10,000.
Absolutely.
So
Yeah.
please consider getting pet insurance without annual limit. Guannan, please continue and share any case stories that you have.
Yeah. So I'll quickly go through, like canine CGP, as we already said, that is not only useful for guiding treatment, prioritization and treatment, cancer management throughout. It can also help, refine or aid in diagnosis in a lot of cases, or molecular subtyping. For example, it can tell apart whether this lesion is a malignant or a benign. For example, in the case of histiocytosis, which is critical, right, for you to make that decision whether you need to start systemic treatment or not. It can help even phenotype molecular subtypes down to a specific cell and a specific type lineage of leukemia or lymphoma. So it's pretty amazing now that we have this comprehensive platform. And can also help with those challenging round cell tumors, such as amelanotic melanoma or histiocytic sarcoma, right? Sometimes even the pathologist cannot distinguish those. So, but at the molecular genomic level, so we can easily make that call. But we're still, we're still at the very early stage, right? We still need to accumulate a lot of data in order for us to confidently say, okay, so this mutation is pathognomonic for lung adenocarcinoma or for histiocytic sarcoma. So we're not quite there yet, but we see a lot of promising signs. The prognosis, I think, is also critical for decision making. So again, right now, this utility is the least utilized utility because most of the data is from the human. So, but as we accumulate, we have more molecular types. Some of them will do better, some of them will do worse. So that can be very informative, right? For example, hemangiosarcoma, where they have some hypothesis that a group of hemangiosarcoma have like a better outcome based on the mutations they have, and the other groups they are more aggressive behavior. So, and this is our hypothesis-driven clinical, because genomic is only one side of the equation, right? At the end of the day, we need to, really validate whether the genomic guided treatments is not only approved in people, but also is useful benefit for our dogs as well. So that's why we hypothesize, to the human inferred biomarker drug evidence can benefit treatment in dogs, but we want to test that in our real world patients, right? That's why we have this very well-designed follow-up process that we have already started, and we have seen a lot of successful cases. So I want to share a couple case highlights today. So, as you all know, we haven't launched VetOmics for too long, but we have started our clinical follow-up studies, and we have always, followed up closely with and we have found that many patients have been thriving on genomic guided treatments, whether this is the target therapy or immunotherapy, which is just makes it totally worth it, make our work, right? And so we have this dog, Oliver, who is a 7-year-old Australian Shepherd, and it's just a happy dog. He loves to hang out in patio chairs, especially the one under the umbrella for the shade. So he's oftentimes competing with his owners for that chair. And he had this slow growing tumor diagnosed as a splenic stromal sarcoma since spring last year. And the tumor was all of a sudden enlarged significantly and removed in August. So the doctor put him on doxorubicin, but he had a really, really bad reaction. He didn't tolerate doxorubicin, which is the standard of care in this case. He didn't tolerate it at all. So he need like alternate treatment options. Unfortunately, his first genomic test from another genomic service came back empty. So that's when we first, launched VetOmics, and Oliver was one of the first few patients that we profiled. And we, Canine CGP revealed that Oliver's tumor is relatively quiet in terms of copy number alterations. He did not have many copy number changes at all, but he has mutations in genes like NF1, mTOR, and he has a super high tumor mutation burden. So based on these insights, we recommended 3 treatment options. And his doctors started on the first one, which is on the combo of trametinib and sirolimus, and he has been doing so well ever since. So he is now in complete remission, and so the doctor switched him, reduced the drug actually to trametinib alone now, and he is just in complete remission, cancer free, and it's been like 9 months out of the test. So it's pretty amazing. And, we couldn't be more happy, more thrilled by this outcome. And
Guannan, can you say a little bit about the cost of typical targeted therapy drugs, per month?
it really depends. I think that's a wide range. For sirolimus, rapamycin, it can be very, very cost effective. But for some others, but in general, I think it's either comparable or less than the chemotherapies. And not to mention that a lot of these target therapies, they are oral. You can administer them just orally. The owner can give them the oral drug at home, so you do not have to go to the hospital to get, for example, a carbo, right, IV injection. So that's some of the benefit. Toxicity wise, they all have toxicity, right? But doesn't make target therapies more toxic than chemo. If used in the right setting, I would say they are probably less toxic. And another case highlight, this is actually recent. Dr. Jeanette Carreras all of a sudden sent me this picture. She was just over the moon because she couldn't believe the response she's getting for Lucy. Lucy, as you can see here, is a beautiful 13-year-old golden retriever. He had two fast-growing left forelimb lesions on his digits, which were diagnosed as cutaneous malignant melanoma with a really high Ki-67 index. And he underwent, they did surgery, but with incomplete margins, and followed by onset vaccination. So in December 2024, so he had another new mass growing on his left lateral shoulder, which was confirmed malignant melanoma with extremely high mitotic index. I think this is the highest I have seen, over 100, and the lymphatic invasion. So this is a pretty metastatic malignant melanoma with a very aggressive behavior. Canine CGP revealed extensive copy number changes and a low tumor mutation burden. So Mark, you probably appreciate this because in most human cutaneous melanoma, it's characterized by high tumor mutation burden, mostly because of its UV induced, right? So that's the signature. but not necessarily for our canine companions. If it's a cutaneous melanoma, the tumor mutation burden is not necessarily high. And we recommended 4 lines of treatment options, among which palbociclib, which is a CDK4/6 inhibitors, is prioritized as the first line. I think Dr. Carreras had her doubts when I tried to push that. Okay, try palbo first. In this case, I think it's a great candidate for palbo. But she did it, and they started a single agent palbociclib in January. The owner gave Lucy one pill of palbo at home, and so she has been doing so well, like the strong, durable response since the start of single agent palbociclib. Lucy continued to be active and happy. Her oncologist, her mom, are just so over the moon about this, and we are over the moon. We're so happy about this. Yeah, we want to see more cases like this, and obviously these are like our star cases, right? But even in like the overall like a systematic follow up, so we see at least 30% of our patients respond to the genomic guided treatments. So I think, that's, with all the confounding factors, I think it's not ultimately our goal, but also not bad at this stage. I think we have to keep it up. And so here are the 4 lines of therapies. And, we have so many mutation biomarkers identified. So a big part of my job is to prioritize, from 5,000 mutations, which one could be the driver. We got a lot of help from the databases, from the algorithms, but at the end of the day, so, prioritize which line should be prioritized as the first line. So is a main part of my job, and I love every single one of it. Yeah, so this is just such a success story that really make what we do really amazing. And besides guiding treatments, canine CGP has been, because of the comprehensiveness and the depth of the sequencing we do. Now we can really, this is a discovery mode for a lot of the biologies that we did not understand previously, right? So we have seen like diagnostic utilities. We have seen cases that are hereditary cancer. We know that dogs must have hereditary disease, but we now have solid evidence that we have similar hereditary cancer driven by similar mutations as our human. And we have seen cancer predisposition biomarkers, and of course, tumor mutation burden, which is the most well-established biomarker to stratifying for immunotherapies. So yeah, if you're interested, we have all these case highlights on our website. Please explore and let us know your thoughts. And this is our team, so very small at the moment, but pretty awesome. So my co-founder, Dr. Ming Wu, he's the top genomic scientist, the solution architect, and so we can make it, make these pipelines and systems very, very tailored and very, very effective. And we have an awesome team of advisors without whom that VetOmics won't be possible. And really, all the doctors and every pets that we have that have used us, right? So we consider, you're part of the community and the family. And so if you're interested, we have included some resources here, our email, website, and we have this is a pretty cool that I had this vision a long time ago. So finally we made that a reality. Is a online precision oncology forum for knowledge exchange. and hand holding, because as we all know, these are pretty, like, sometimes really uncharted territory, right? Nobody know how to dose, use extreme example, how to dose trametinib in cats. But it really requires like a crowdsourcing knowledge. So that's what this forum is for. Granted, it has not been fully utilized, but I hope eventually we can utilize it more. And besides the case highlights, so we've also recently tried something that are really out of my comfort zone, but I did it anyways. I'm doing it anyways. It's a podcast where we engage like leading clinicians to talk about the challenges, the practicalities, and the promises of genomic diagnostics and omics guided treatments options. I think we're just this is so new. Nobody has the right answer. We just need to collaborate and generate good data, talk about it, and at the end of the day, this is all for advanced cancer care, right, for our pet families. So that's it for me.
Thank you so
Thank you so
much.
much again. Yeah.
So we have a lot of questions. First of all, how much is the test?
So we charge clinicians $900. So I understand that some hospitals they have a markup. Yeah, the markup space is all over. It's really all over the range. Sometimes they mark up like 20-30%. Sometimes it's extremely high. So it really depends on the hospitals. Yeah, but I hope, at the end of the day, this is a diagnostic tool, right? So we haven't even got into treatment yet. So, we do not wish to see that a diagnostic test cost $3,000. It doesn't make sense, right? So, like we hope that, to work with the hospitals and doctors to see that, in order to democratize, to make this more widely adopted and used, the cost has to be reasonable.
And pet owners cannot order it directly?
For right now, so we encourage you to work with your oncologist or your family doctor to order from us. Yeah, I have a lot of owners now who probably heard us from LinkedIn or word of mouth, that they actually push their doctors to order. But I do receive a request from a lot of pet owners as well. They are actually guiding which one we want to use. It's pretty awesome. Yeah.
Can you say a little bit about how this test is different from other genetic tests that we hear about?
Yes. So first of all, the genomic footprint that we cover, right? So I know other tests, they cover either less than 100 or just above 100 genes. And we cover the entire coding exome of 20,250 genes. What does that mean? It's not just a number, right? That means that we can really, analyze this individual tumor like in an unbiased view. We have the most chance to identify what's the most likely driver and what's the most likely mutation that can respond to therapy, because you want to target those, right? And if you measure too few genes, right, just a couple hundred genes, not even that, the likelihood of missing something critically important is very high. That's why, that speaks also the quality of the test, that we haven't had one empty results yet. Fingers crossed that we won't see a lot of those, but all of our cases, 244 clinical cases, we have also sequenced research cases as well. We haven't had any, one case that doesn't have any mutations or potential drivers that we cannot act on. Yeah. So it comes down to getting the most of getting the most of the test. Yeah, getting the most of the information, the best information.
That's why it's called CGP, the comprehensive
genomic profiling. Yeah, and this is I didn't invent the name. I was not smart enough, but I like previously in the human space, a lot of times it's single gene test, right? But there's also a trend moving away from the single gene or multiple gene test, like a small panel test, to comprehensive genomic profiling. Why is that? Because you want to, again, cover all your bases so that you don't miss anything, right? So the fact just because there is an oncogenic mutation doesn't mean it's absolutely the driver. Maybe it's just present in a small clone of the tumor that you won't respond to therapies. That's why we need to really cover the whole gene. And the reason for whole exome, is really extreme comprehensive genomic profiling is because we just simply don't have the knowledge accumulation as human did, right? So for one mutation database like Cosmic, for example, it has already had tumor genomic mutation data for more than 1.5 million tumors. And how many do we have? A few thousands. So we just don't yet have that knowledge to really say, oh, I can focus only on these 100 genes. These 100 genes are based on humans, not based on canine. So that's why I've always not a big fan of smaller, like targeted. So when I go big, but of course, cost come with it, right? Fortunately, it's not too extreme, the cost difference. But definitely
your test is not 2 or 3 times the cost of the other
not at
tests.
all.
It's just tiny bit more
Tiny
expensive.
bit more, yeah, tiny bit more.
And it can do tumor mutational burden.
It can do tumor mutation burden. Yeah,
Can you
yeah.
explain what
Tumor
that
mutation burden. Tumor mutation burden technical definition is how many of the missense mutations you find in this tumor per megabasis, right? So tumor mutation burden, the whole exome sequencing is the gold standard to measure tumor mutation burden. And we are doing whole exome sequencing. In human medicine, there are a lot of surrogate of whole exome sequencing to measure, to evaluate tumor mutation burden, but it has to be like it has a clear criteria. Your panel, like the size of the genes that you measure, has to surpass a certain size in order to have a good correlation between the whole exome measured tumor mutation burden versus a targeted panel. Yeah, that's why it's added benefit, right? But tumor mutation burden, because of its significant role in predicting immunotherapy response. So that has always been our goal, to include the tumor mutation burden. And it's not the only one. It's not the only biomarker, right? There are genes, gene mutations, gene losses, or there are microsatellite instability. There are many other genome-wide or gene-level mutations that can predict, but tumor mutation burden by far has been the most reliable and established one. And without, this is again all very based on first principles, right? We just have to see, whether it will actually, the autologous vaccine, there are literatures in the human space that shows that, high tumor mutation burden, elicit more response to autologous vaccines. Yeah, we just need to see that. Right now, we interchangeably recommend autologous vaccine or immune checkpoint inhibitors like Gilvamab. Yeah.
Okay.
Yeah.
So
and for the Yale vaccine, since Mark is here, so it's because it's different mechanism, right? But we have a expanded list of genes. ERBB2, EGFR, ERBB4, and others, EGF, like all this group of genes that might work in that pathway. So if we see a high level amplification, we also recommend EGFR. Yeah, vaccine.
So I know that in human medicine, immune checkpoint inhibitors are extremely expensive, hundreds of thousands of dollars for treatment. So you would use TMB or something before you choose to do immune checkpoint inhibitors. For dogs, they're also quite expensive. So I
Definitely
guess you don't
good.
have data yet, but based on the human experience,
Yeah. Yeah, it's definitely good to stratify patients. Yeah, we have some patients that are, GilVetMab that are doing very well in the high tumor mutation. We just need to follow up longer to see if we see benefit. Yeah, yeah.
And how long are the mutations stable though?
Yeah, that's a great question. So why is DNA mutation the most established, biomarker, right? To stratify patients to predict treatment response. It's because DNA is relatively more stable than mRNA, than protein, right? So we can unless it's under drug pressure, right? Or under other evolution pressure, a new clone grows out, right? So DNA mutations are a lot stabler than for example, if we measure expression of a gene as a biomarker, we do have those, but like a lot of factors can change that.
Mary, I think if I can interpret, maybe what you're asking is, do the mutations change in a particular tumor in one dog over time? Is that what you're asking, Mary, about stability of a mutation? If
Right.
you
So how
measure
long is the targeted therapy good for? Is it effective for 3 months or 12
right.
months? I know the answer is it depends, but just from your experience, what are you seeing?
It varies. It really depends, right? Like some like the two cases I just showed, they are 9 months out and they are still doing good, right? And sometimes a new clone might pop up. There the resistant clones resistant mechanism. The tumors are super smart. They are suppressed in this pathway, so they tend to mutate in another pathway, right? And then when that happens, a new clone grows out, and then now your targeted drug, original target drug, doesn't work anymore, and you have to use another drug. That's why. So I think from in human space, the way to tackle that is by combination therapy. From the get-go, you kind of target multiple pathways that this might mutate, and you potentially get rid of all the resistant clones from the get-go for best control. It's not 100%, but that has been a trend, is to use combination. The reason that we recommend trametinib is sirolimus with the right appropriate biomarkers is because the MEK inhibitor and mTOR inhibitors, PI3K pathway and MEK, RAS, MEK pathways, they are like the most commonly mutated and utilized pathways, right, in human cancers and in cancers, period. And if you target both, a lot of the, even the downstream, upstream, even EGFR, right, ERBB2, at the end, eventually they will, merge into, some of these two pathways, if you kind of block those, so you might have a more chance of better control. Yeah, but combination I see is the trend based on what we learn from the human side. And now we have the or we now have the luxury to also have immunotherapy. I just still can't get over the fact that we have immunotherapy for our dogs, thanks to scientists like Mark, who made that happen, right? So we can potentially combine immunotherapy versus target therapy with the appropriate biomarker indications. I think it can go a long way, pending toxicity side effect evaluation.
Yes. So Mark has a study that's looking at combining his vaccine with immune checkpoint inhibitor, gilvetmap, with hemangiosarcoma patients.
Yeah.
So we're waiting for that result. And he
Okay.
also has another cohort that's getting palliative radiation with his vaccine, no surgery. Palliative radiation is sort of like in situ vaccination. So it's not called immunotherapy, but it is sort of immunotherapy,
Okay.
partly. So maybe that might help as well.
Yeah.
So there's so much potential here, possibly combining autologous vaccine with Mark's vaccine as well.
Absolutely.
So we often get emails from pet parents who says that their dog has metastasis or tumor that you can't access easily, so you can't biopsy because it's already in the lungs or it's a liver mets or something. So in that case, can they really send you a blood sample then for you to see if there's a matching targeted therapy?
If it's a metastatic disease, so there are two ways, right? We can sequence the original tumor because even though the tumor has metastasized, it will still maintain, most of the times, it will still maintain the truncal mutations, like the original mutations. And of course, we want to control the metastatic disease, right? But if the tumors have not seen target therapies, that are present in the primary tumor or in the mets, so using the primary tumor. Actually, I prefer to use the primary tumor.
Then the blood sample.
Then blood sample is we have to really, if we cannot assume blood sample is you have to have a very specific way of this is my cat Jesse. He likes to check on what's going on, and so blood, we have to have a remember, we have to collect the blood in order to collect the cell-free tumor DNA, right? So blood has to be collected in strep tubes, for example. So it cannot be just in purple top, right? Or so there are very specific ways, and oftentimes, so to make things easier, our test right now is not designed for circulating tumor, for cell-free DNA. So for those two, because it's very the DNA is a very, very tiny amount, right, in the blood, even after you enrich for it. So oftentimes what the field is doing is to have for example, UTI, unique barcode, in order to identify or tag the different molecules. So that's down the line. I see we probably move to that direction, but
if I can interject, Dan on the online here is asking, for dog with osteosarcoma, is a tumor biopsy required? I guess the interpretation is yes, But I think it's important for people to know that if there's tissue from surgery that your dog had, whether it's osteosarcoma, amputation, or hemangio, tumor taken out for pathology, the pathology labs frequently maintain or keep those tumors.
Yes.
Retrospectively, you can go back if your dog had surgery 2, 3, or 6 months ago and has progressive disease, and you want to now test the genomic burden, you can still do that. You can get tumor from these labs from your own dog.
Mhm.
And I think, as Guannan nicely described earlier, they can purify the DNA and do the testing from pretty much any sample that goes to a pathology lab.
Okay. Yeah.
Yeah,
So
absolutely.
in your
Yeah.
slide,
And
when you said blood, you meant really for like blood cancers as opposed to
leukemia. Yeah, where it's
infusion.
in full blast stage. Yeah, that we use blood. Yeah.
Got it. Okay. Um, let's see. Kona is asking, have you found any cancer-associated mutations in genes that have not previously been linked to cancer?
Great question. Yeah, that really taps into the discovery of exome sequence comprehensive genomic profiling in canine cancers, right? And we do see that genes that are mutated that were previously not indicated in human cancers or published canine cancers. So the answer is yes. And these are new discoveries, we'd like to publish that are unique to canine cancers. And also to circle back to the previous question, so we work with all the major pathology labs so they can get their samples. If you make the request or your doctor make the request, they can send us the formalin fixed samples that we will use. And your doctors can also get maybe a new aspirate. That's also possible. Yeah.
So it's never really too late to get this done.
I would think so. Yeah.
No, this is fantastic. Let's see. Um, are there any cancer types that you think this test is particularly good for, from your experience?
So we have to like start with the most severe or the least like the ones that has the least favored outcome, right? For example, hemangiosarcoma. And we see a lot of hemangiosarcoma cases, hemangiomelanoma, osteo lung adenocarcinoma. So if they are like, yeah, we see a lot of those, and we haven't followed up long enough in our previous surveys, but we actually published from my previous role that like long-term follow-up, right, of genomic guided treatments versus standard of care. So we actually have a significant and durable separation of the Kaplan-Meier curve, of the survival curve. So I think, yeah, it's definitely there. But I would say that we see a pretty well represented cancers from all cancers, but we definitely see more hemangiomelanoma, lymphoma, what else? Lung adenocarcinoma and the sarcoma. Sarcoma as a whole is very, very tricky. Oftentimes, like before CGP. So my experience with soft tissue sarcoma, splenic stromal sarcoma, is that they are oftentimes very, very quiet from genomically speaking. And we don't know what's going on there. But right now, I think CGP is really picking up a lot more signals that it can potentially drive sarcoma, these sarcoma subtypes. Yeah.
Okay.
Yeah. We see a
That's
lot
good
of
to know.
sarcoma. Yeah.
Now, so you brought up the combination approach is the best. And by the way, on Friday we have another webinar. Ardent Animal Health has autologous vaccine, and they have a new clinical trial that's enrolling dogs with osteosarcoma. And these
Okay.
dogs are getting combination of their autologous vaccine plus a new immune checkpoint inhibitor, not Gilvatimab, not PD-1 checkpoint inhibitor, but something called it's a CD200 that blocks a couple of different checkpoints.
Mm-hmm.
So,
Yeah.
and that was trialed individually. They've been tested. That
Okay.
checkpoint inhibitor was evaluated first at I think Colorado State University. But anyway, it's a very exciting
Exciting times.
trial. There's a lot of enrollment sites. So we're going to talk about that on Friday. But when we talk about combining targeted therapy, chemo, and immunotherapy, Mark brought up a really important point that some of these targeted therapies can be immune suppressive. It could
Yeah.
interfere with immunotherapy.
Yeah.
So can you say something about like which targeted therapy drugs that you have to be especially careful of? Used in conjunction with immunotherapy?
Mm, I'm not well versed in that space to say definitively. Yeah, I have heard that rapamycin because of the like the wide involvement in basically all different cellular process, right? It can be suppressant, but yeah,
Well,
yeah.
rapamycin, I think, is used for people who get transplants to suppress immune response, right? So that we know it has very strong immune suppressive effect. But I suppose if we looked at the list of 17 or 18 targeted drugs that you map into, then we can find out which of them might interfere. Mark, what do you think?
Yes.
Yeah, absolutely. Yeah. And if you guys know any others, so I'd love to work with you guys to, map those out because it is a critical, right? If our doctors see, Gilvatimab or EGFR vaccine recommended as the first line, and then there's a rapamycin recommended as a second line, they could go, okay, why don't I, combine these two? But as a matter of fact, we can't, right? So it's definitely good information to have.
Okay.
Yeah.
Now, how long have vets been using CGP?
How long? We soft launched our service since October last year. And so we really waited until earlier March this year to officially launch. So not too long. Originally, we were only launching it to a small group just to make sure that we get our assay really tightened up and all the kinks figured out. Some doctors, they did also help us optimize our pipeline. So I was eternally grateful for them. But we took the time to really optimize the assay and launched for March this year. So we have grown from the initial like 10, 15 doctors to right now 60 doctors that are registered with us. So not huge yet, but we definitely see more doctors that are interested in us. And we now also see a trend that we actually get requests from the owner and then the request from the doctor because the owner kind of pushed on their end. Yeah, which is pretty awesome. Yeah, and the change. Yeah.
Okay. So we talked to some researchers who are looking at adding propranolol as part of hemangiosarcoma treatment. And there was a hypothesis that genomically there is a difference between hemangiosarcoma patients, and some of them might benefit more from propranolol than others. And so I was curious if you've looked at those papers and if you can, if your test can make a recommendation for using propranolol. Propranolol,
Happy.
by the way, is a very cheap, widely used beta blocker used by people with high blood pressure, and it's also prescribed to dogs as well.
I have to look into those papers. Not yet familiar with those studies.
This has been great. Thank you, Guannan. Thank you, Mark.
Thank you. Yeah, for this opportunity. So it's been pretty great. So we've been presenting our service and our tests like amongst mostly the clinicians, right? So this is the first time that we can now have the opportunity to also engage with our pet owners. So which is yeah, I hope is a learning experience for all of us that what the pet owners are care and what we need to work towards, right, to make these tests more available.
And also the targeted therapy drugs, the number of drugs is increasing. And I
Yes,
had been worried that they're quite expensive, but it looks like if you actually do a little bit of research, depending on where you get the targeted therapy drugs from, it could be there could be a huge difference.
absolutely,
I looked
absolutely.
at
Yeah. So
one and
definitely do some research.
$700 a month, and I found another one that's $40 a month. So it's really
Yeah.
worth looking up.
Yeah, and sometimes if you use the generic human version of the drug, it might be less expensive if you get the drug from a compounding pharmacy, a veterinary compounding pharmacy. So there are a lot of ins and outs in there too. On that front, so we're not quite satisfied with the 18 target therapies that we can recommend, right? So I feel like genomics now is overkill, and we are like limited by what drugs that we can recommend. Humans has more than 200 targeted therapies that they have on their dispense. But like we are also working with some of the veterinary pharmaceutical and compounding pharmacies, to say, okay, these are the drugs that we see that have a lot of for drug companies, right, or compounders, compounding pharmacies, they need to have they need to justify the volume, right? So that's why I think now that we kind of have this capability to say that, okay, this for example, we see a lot of MDM2 amplification in canine melanoma. Can we bring in a MDM2 inhibitor for dogs use? So right now, so they have perfect MDM2 inhibitors in humans. We just can't access it. Can we bring those? And that can be a huge game changer, right? So now that we don't have to compromise what drug we can recommend or we can use. Safety is a great, like definitely something pending safety evaluation, right? But at least I'd like to see more drugs become available for us to use. Yeah, and that's also another, like effort that we are making. So like trying to rationalize drug repurposing, drug development, right? And
So just to reemphasize Mary's point, I have personal experience with this is not only cancer drugs, almost any drug that your pet may receive can potentially be significantly less expensive at different sources. So if you feel like your medication you're purchasing for your dog or cat is too expensive, have a honest conversation with your vet and say, have you looked at other suppliers for the cost of this? It's a simple question that could save you a fair amount of money.
I
I
think
mean,
one
I can tell you, for example, carprofen, which a lot of vets are using in combination, relieving pain and inflammation in the context of surgery or cancer care can very widely.
And also insurance, pet insurance. Please consider getting pet insurance. All right. Well, thank you so much. Thank you so much, Guannan. Thank you so much, Mark, for everything that you guys are working on. Thank you, everybody, for joining us today. We'll be having another webinar Friday this week, but it will also be recorded. And if you have any questions or if you have any suggestions for future topics that you'd like us to cover, please email me and we'll do our best. So thank you so much.
Yeah. Thank you, Mary, for bringing us all together, right? It takes a team to
All
tackle.
right. And your forum, that's only for clinicians or can regular people join your forum?
So when we original plan is for all registered clinicians, but for right now, so we keep it open to public just because we want everybody to see, what we are up to and the knowledge exchange and like the topics, right? So right now it's open to public. Anyone can see it.
Well, that's very cool.
Yeah.
All right. Awesome. Well, thank you again. Bye, everybody.